Oh, it's a real privilege being here today, and I don't know whether it was a good idea to turn up first thing this morning, because with each of the presenters, I'm thinking, oh, I could mention that. So please forgive me if I mention a few stories. The first one is the first funeral I ever did. I must have been about the age of late 20s or so, and it was a cremation. And I was never too keen on cremations. And I went to the crematorium, and there's the little pulpit to stand in, and there's a brass plaque in front of me. And it started off with a little quote from the Bible, but then it swapped it. And it just said, there's a time for living and a time for dying. Your time for this ceremony is 20 minutes. Any longer and an alarm will be sounded. So apparently I got to 4 o'clock and then sounded the alarm, okay? Yeah, so you might be wondering, well, how is he coming here to talk about sex? And fancy leaving sex till the end of the day. Left and right till the end of the day. But setting it within this focus of breaking taboos, and this was the title really I was given to consider. So God, sex, death and dying. And it's going to tap into so much of the stuff that we've been doing right throughout the day. My original profession was nursing. I started at the age of 17. I did orthopaedics. You could do that at 17 in those days. And then I did the good old SRN. And then I took a 10-year break out of nursing. And when I went back, I was working on an HIV ward, and that's what got me into teaching sexual health. So some of the stuff you've been saying today, I'm thinking, well, certainly in the field of HIV, it was the exact opposite, the other way around. Even when Poppy was saying then about people wanting to paint, somebody wanting to paint her mum's fingernails and toenails, I can think back to an awful story. When I worked on the HIV ward, we had this woman from abroad that died with us, and her family didn't have the money to come over for her funeral for quite a few weeks. So they kept her body in the hospital fridge for a whole month before the family could come over. And when her family came over, the staff working in the mortuary didn't want to touch her body because she died with an AIDS-defining illness. And this is back in the 1980s, when there was lots of fear and panic. But they thought, she's been in that fridge for a month, we don't know what's happening, we won't touch her body. So it was the nurses from the ward that had to go down to actually retrieve her body out of the fridge and make her look presentable, ready for the family to see. And one of the nurses, I'll never forget it, she said she could just see the nail varnish on her nails that she painted on the day she died. And it was like a month earlier. So her bereavement and her grief and loss then moved on in so many ways, and here it was sort of being resurrected by seeing this. So this is what we're going to be doing, especially talking about some of the taboos. And some of you have started mentioning those already. So yes, nursing, took a 10-year break, I'll tell you about that in a moment. Then I worked on an HIV ward, and I've now been teaching sexual health since 1990. And my poor old mother, she died 21 years ago on Monday, just gone. And when I first started teaching sexual health, and I was telling her the type of stuff I'd be talking about, she said to me, you get paid to talk filth. Right, so hopefully the rest of the afternoon we'll be talking filth, okay? Right. So, this is the day job, this is what I actually get paid for talking this stuff. So we've got so many courses, some of them are online, some of them are classroom, and we've got enough at level 6 for nurses in particular who have got a diploma to do a top-up degree in sexual health. We've got a master's degree, we've got doctoral students in sexual health. So we've got loads of different things, so there's lots of people talking about sex, all right? And I bet you that so many of your clients would like to as well. Can any of you remember those old admission forms when a client went into hospital, and you got those forms, like I mentioned this morning, but religion, and it's as if automatically everyone's got a religion, because just the way it would say it was religion, and then some people would get a bit shifty and embarrassed, well actually I haven't got one. It was as if there was a default. And there also used to be a little box on it that said sexuality. Can you remember? What have you seen written in that box? Yeah, just left blank.
No concerns with body image.
What's that?
No concerns with body image.
Where's makeup? lives at home with husband and 3 children. That sort of stuff. One nurse I was talking to, she said, well, she saw written on the box, over 40. But also, you may find that, especially, say for example, for older people, you might see it written down as NA, not applicable. So lots of nurses have got a problem. Nurses and other healthcare professionals have got a problem talking about sex. I really haven't. So don't worry about that. But this was me at the age of 30. That was that 10-year break. So I spent 7 years studying to become a Catholic priest. Then I was ordained as a priest, and after 3 years, I packed my bags and I ran away. And that's when I went to work on the HIV ward. But that's how I've done so much around the God, the sex, the death and dying, because of that. But there are some little stories I wanted to tell you. One of them I'm going to get a bit emotional about, so maybe I won't tell you. I should have videoed it first. But some of them, one in particular, this story I'll never forget. I visited an 80-year-old woman at this age, 30. So I was the priest in her parish, and I went round to visit her because her husband had just died. So I went round on a bereavement visit, thinking, right, this is what I'm going to talk about now, death and dying. And when I got to the house, she invited me in, and she said, look, there's something really embarrassing I have to talk to you about. And she said, it's even more embarrassing because you're a young man and I'm an old woman. And when she sat down, she touched her legs, and she was wearing trousers. She said, look, I started wearing trousers before the Second World War, before women generally wore trousers. And she said, because as a little girl, my parents beat me badly. And she said, my legs are covered in scars, so I've never wanted anyone to see my legs. And then she nudged me, and she said, my old man was always good to me in the bedroom department. And she said, but after my first baby, my womb dropped, and I've never been able to tell anyone. And she said, so for 50 years, I've suffered this pain. And she said, he was good to me, but I've never enjoyed sex. I just thought it was my duty. And she said, but last week, a brand new lady doctor came to work in our clinic, in our surgery, and that's the first person in 50 years I've told about this. And she said, she put this thing up inside me. It's a little ring pessary to hold her womb back in place. She said, Father, I've been walking around with a smile on my face all week. Do you think it's a sin? She was having multiple orgasms. Every time she moved, the position of this thing was giving her better feelings than the old man ever did. But that's why it was important to her, because she thought she was now betraying his memory. Because she was getting better feelings from this than him, should she have it removed. So please, you never retire from sex. Yeah? So no matter what age, but think of all the different ways, no matter what age a person is, what experiences in life, there may be some of those questions. As we were looking at this morning around spirituality, sometimes people want to ask questions, but it could be things in their past that they may want to talk about with sex. Now it could be regret. Maybe somebody said, well, if I'd known I was going to die this young, I would have done it a lot more before I die. It could be anything around regret. Or maybe experiences they've had, or issues they haven't resolved. There can be so many things. So if you want to write on the form, not applicable, or leave it blank, you're doing them an injustice. Because there could be something they want to talk about. Just because someone's given a diagnosis that means at some point in the future they're going to die, doesn't mean it's only that way they're focusing in life to talk. They may want to look back as well and talk about some of the other issues. So this is what we'll explore. I don't mind you stopping me at any point. If you want to challenge or question me, you're stopping when you want to, okay? Right, this bloke here, Michel Foucault, wrote this fabulous book called The History of Sexuality. He wrote a few volumes. Have any of you come across Foucault? Yeah? Okay. In The History of Sexuality, Volume 1, there are a couple of short things that he said that I think are really important for what we're looking at today. The first one is he came out with this term, triple edict. And what he meant by that was anything that's a taboo, that's silence, we're just not going to talk about it, and if we don't talk about it, then presumably it doesn't even exist. Okay? And when you think of all the different aspects around sex, sexualities, or sexual health, one of you this morning said, what do we mean by sex? Yeah, so what do we mean by sex? It could, the rumpy-pumpy stuff. It could be that. It could be how somebody feels about themselves, wears makeup and got 3 kids at home. It could be how they define themselves. There are so many things that's involved in sex, sexualities, and sexual health. Okay? So those 3 things. But Foucault, especially in relation to sex, he said that so many people don't like talking about it. So we sort of sweep it under the carpet, and if it isn't spoken about, then it's as if it doesn't even exist. So if I said to you now, with all the clients that you care for currently, how many of them would say that sex is really important to them at the moment? You may say, well, not many actually, nobody's ever told me that. Because maybe nobody's ever talking about it. And if they don't talk about it, does it even exist? And that's one of the big problems there. So this triple edict, looking at taboo, and we'll explore the taboos in a few moments. Are you okay? Yeah? Okay. Another thing he said, especially in relation to religion, so the very fact I've been asked to talk about God, sex, death and dying, why do we still burden ourselves today for once having made sex a sin? And when you consider the ways in which some people may feel guilty about certain things, and this morning we were looking, maybe somebody needs to get something off their chest. Well, it could be in relation to this as well. But if you never mention it, if you're sitting there with your clients thinking, well, I can ask you about whether you've made a death plan, I can ask you whether you've made peace with all your family, I can ask you those questions, but I'm not too comfortable asking about sex, so I won't mention it unless you mention it to me first. And the client may be sitting there thinking, there's one thing they just haven't mentioned to me and I wish they would, because I don't know how to mention it to them first. So you're both stuck. Nobody's mentioning it first at all. And it just takes... Now, I've just thought of another story. What time will we finishing, you say? Another one. I spoke at a conference a few years ago for practice nurses. And a nurse, she was 65, and she came up to me and she said, this is my last month of working. I'm 65 and I'm just about to retire. She said, now you won't remember me, but you spoke at a travel nurses conference a few years ago, and I was there. And she said, when I go to conferences, I never take notes, I just remember one key message from each person. And you said to all the travel nurses, whenever you're doing a travel consultation, never let a patient or client go without mentioning condoms to them. And she said, even if they're really old, an old couple coming in, I'll always say, are you all right for condoms on your holiday now? And she'll say, more often they'll laugh and they say, well, we don't need condoms, but actually now as you've mentioned it. And she said, it's like opening a tin of worms. She said she's learned more in the last 5 years of nursing than over her whole career because she mentions this one thing and she said they just spill their guts about it. So we really need to sort of take that on board there. Now, when I was preparing this, I did one of these word clouds, and these were just some of the words that came to my mind as I was thinking about this particular session. Look how many of them are the really constructive, positive, life-affirming, enhancing things, but look how many of them can also tap into negative sides of a person's life. And when somebody is moving towards death, look, when I asked you what have you seen written on the forms, another nurse told me once, she was working with people who had cancer, and she was asked, do you ever talk about sexual health? She said, oh no, they've got cancer, sex is the last thing on their minds. Now that was her assumption. It's not necessarily the client's assumption. And one of you told me at lunchtime that there's nothing about sexuality on the forms. What was the name of the forms you fill in? Yeah. So there's nothing directly mentioning sexuality there. Now, I'll come on to losses in a bit, but look at the way in which some of these things may relate to your clients. It could be that someone says, well actually the medication I'm taking at the moment is making me really horny and I don't know what to do about it. Somebody else may have the exact opposite. They may say, I'm completely washed out, or I've got COPD and I can't breathe. And especially if they think that sex means doing it like that, and that this is the person with the COPD, but maybe nobody's ever said to them, have you thought of doing it like that? Yeah? It could be that you just need to think of things differently for them, but if nobody's had that conversation, or supposing somebody's in pain, whatever their condition is, they've got pain, and they take their Oromorph, they take whatever they're using, and the pain goes after a while. So they say, well, my partner and I, we used to have sex when we'd wake up every morning, but I'm in so much pain then, so what about take the medication and wait until that kicks in, and then have sex? It made me, like I've written a bit, Shut Up Shop. That was one of my old neighbours. I don't know how she got onto this, but she said to me, Dave, you know, my husband and I, we shut up shop years ago. Yeah? And she just said, well, that's it now, you know, just no more. But it could be because maybe they are feeling tired, or look at the therapies that would change a person's body. Yeah? If it's a female, maybe she's got dryness in the vagina. A man, he may have erectile dysfunction. And they may just, well, that's it now, that's the medication I'm on. And they don't think of talking about it with anyone. So that can be really significant there. So these were just some of the words that I came up with, and hopefully you'll generate more as well. Now, thank you people. That's all of you. That's all of your clients. We're all sexual beings. And in the caring professions, we've been banging this drum for the last few decades, saying we care for our clients holistically. And maybe you've even heard that saying, there's no health without mental health. Well, I'd say there's no health without sexual health. If we're not addressing a client's sexual health and well-being, forget it, you're not caring for them holistically. You may be spectacular at looking after their physical signs and symptoms. You may be great at talking about their psychological angst. But if you're not addressing the sexual side of their lives, that's not holistic care. You're ticking some of the boxes, but not all of them. Okay? So that's you and that's your clients as well. A few years ago when I did my own doctorate, I looked at ways in which sexual health can be relevant right across life and in different ways. So in the centre here, for each and every one of us, what does sex, sexuality and sexual health mean to each and every one of us? That's the holistic bit of it, and I'll come back into that in a moment. But also, look how sex, sexuality and sexual health, look how they can be impacted on negatively by other health conditions. So it could be secondary to that. So supposing a woman has a mastectomy, and look at the way in which our culture often talks. Look at some of the newspapers, the way they present women, nakedness, breasts, and all of a sudden she's now had a mastectomy, and she might think, well, I don't even feel feminine anymore, because she doesn't fit into what society or culture often says is feminine. Okay? Another example I often use on this one is type 1 diabetes, well, type 1 and type 2 diabetes, that 50% of men with type 1 diabetes will have erectile dysfunction. That's 1 in 2. And yet the diabetic nurse specialist may be fantastic at talking about blood glucose levels, how they manage their diet, all the things they should do. But if that nurse doesn't say, and look, 1 in 2 men with diabetes will also have erectile dysfunction, how is it affecting you? If they don't have that conversation, they're not caring for them holistically. Now, in all the clients that you care for, the different types of illnesses they've got, look how those illnesses may have an impact on how they feel about sex, sexualities or sexual health. So there's that as well. But also, whenever people say, oh, you talk about sexual health, what does that mean? Teenage pregnancies, sexual infections, HIV, abortion, it's those things. That's what people often think of as being the specifics of sexual health. Well, that may be important to your clients as well. It could be that some of them have got sexual ill health problems, or maybe they have in the past, or maybe they've got a lingering guilt about something from the past. Okay, so they're going to be really important there. So I say right across life, those 3 domains. I'll just focus in on the holistic one for a moment. So holistic care, just give me some buzzwords. What does holistic care mean to you? Total. Yeah, okay. Yeah. So again? All encompassing.
Whole self.
It's what? Whole self. Yeah, really lovely. Natural. Yeah. Yeah, and very much, especially from the point of view of what's more natural to life than sex. If your parents had never had sex, you wouldn't be sitting here now today. Okay? It's as
One
basic.
doesn't go there.
I get paid to talk filth. Yeah, right, so natural. So whenever we're talking about holistic care, in fact, when I did my doctorate, I was doing some focus groups with nurses right across England, and I was asking them, well, what did you do about sexual health in your pre-registration education? It's worth asking all of you now. And I said, what did you do? And this one nurse said, well, actually, we didn't do anything at all. In 3 years of registered nurse education, she said nothing. She said, except one day the sister tutor said to us, if ever we were giving a young man a bed bath and pulled back the sheets, if he had an erection, just flick it with your pencil. That's all they were told in 3 years. Anything about sex, that was the only thing that was mentioned. But when you think, when we're talking about sexual health, so it's whole beings, whole people. So that word there, soma, somatic, we're fantastic at dealing with the somatic, the physical, the body. Okay, so I started off doing 2 years orthopaedics. If someone had a broken leg, I knew what to do about it. I knew how to turn a person in bed to stop them getting pressure sores. There were all those things. We can be fantastic at dealing with that. The other side that we're usually quite good at as well is the psychological, the psyche. But look how there are so many taboos and stigmas, especially around mental ill health. Supposing you're on a bus or the tube, especially in London, if somebody jumps on the tube and they've got a broken leg, they're in plaster Paris and they're on crutches and the tube is full, you watch people offer up their seat. More often than not, someone will offer up the seat. But if someone comes on and they've got some sort of mental health problems and maybe they're shouting out or swearing, and people go, oh please don't sit next to me, don't sit next to me, and they just want to avoid them. So some people find it difficult dealing with mental issues. But how many of your clients would have psychological angst so much that they would be talking about very bleak things or dark things, dark places in their mind where they find it difficult to go, or they may say that they're feeling depressed? How good do you feel at dealing with that? Hopefully you are going to be really good. Okay? So the physical and the psychological, hopefully most of us are really good at that. The next area, and this is what we were looking at this morning, that word, pneuma, it's where we get a pneumatic drill from. So what's a pneumatic drill? How does it work? Air. Yeah, air. So pneuma, what's a pneumothorax? Air in the lungs. Yeah, okay. So pneuma, it's for the ancient concept for spirituality, and the little group I was in this morning, we were trying to think of alternatives for the word spirit, spirituality. So pneuma, that was that word that meant it's a person's breath within them. In fact, in ancient Hebrew, it was called ruach, a person's life breath. And they thought the moment of death was when a person breathed out their ruach. When the last breath went out of them, that's when life left them. Okay? So, even when we were looking at spirituality this morning, and again that assumption that everyone has got some sort of spirituality. So what's your religion? Automatically you're making an assumption about that. But someone may say, no, actually I haven't got a religion, and I don't even refer to it as my spirituality. But the thing that's so important to me is, when you put me in a room, make sure I can look out of the window. Because I love seeing the leaves on the trees. Because I know in the spring those leaves are coming back again. They're going to get a really good sun drenching in the summer. They'll go in the autumn and winter, but I know next year they're back again. So don't put me in a room that's got no windows. Now that's what's meaningful to that person. So they may not say they've got a spirituality, or they may not feel particularly religious, but nevertheless they've got a belief system that's giving meaning in their lives. Okay? And again, you may be really great at dealing with that. Look at all the stuff you said this morning. It shows that you are confident and competent in talking about spiritual issues. So whatever you're going to call them, there's that element. But let me show you this final bit then. That's 3 different words there: agape, eros, and philia. 3 ancient Greek words that mean love. Okay? Now, agape is translated in Latin as caritas, charity. What's this organisation? It's a charity. Okay? So charity, giving love to our brothers and sisters, our families, it's caring for each other. So whether you mean that as the whole world or individuals, caritas is that love for each other. The word philia, what words do we use in English that's got philia in it? Say again?
Brotherhood.
Yeah, brotherhood. So, what word is that then?
Filial.
Yeah, filial. Philadelphia. Okay, so it's cheese or the city of brotherly love. Yeah, right. Philadelphia. Yeah, philia, brotherly love. What are the words? This morning when we were in the big pile of books, is it Joe?
Yes.
Yeah. Okay. The big pile of books.
Yes.
Bibliophile. Someone who loves books. Okay. Any others?
Philosophy.
Yeah, philosophy. Sophia is wisdom. So a love of wisdom. Yeah. What about haemophilia? Literally a lover of oxygen. Okay. There are also some very negative words that we now use with this as well. But basically, it started off. There's the charitable love. There's the sort of brotherly love. You may say, look, I really love my best friend, but that doesn't mean you want to get genital with them. It's not that sort of love. It's a different type. It's the brotherly, the sisterly love. It's a different type of love. But this is the rumpy-pumpy stuff, eros. Okay? Erotic. It's the erotic type. But just because your clients have been given a diagnosis doesn't mean they cease being erotic people. But they may feel that. Supposing they're having radiotherapy or surgery that's changing, altering their somatic image. They may say, well, look, my body's changed now. I look completely different. Or I've got no energy. So that's all the physical side. So you may be fantastic at dealing with that. You may be able to talk about a prosthesis for some people. Or wearing clothes differently. And they may say to you, but it's still not that. You know, my partner never looks at me in the same way anymore. There's the erotics. There's that side of it. They've lost something. And just because their diagnosis is leading them in a particular direction doesn't mean that automatically they accept that they're at peace with this, of losing this. Okay, so the erotics, really important. So if we're missing out on those 3 there, I'd say you may be brilliant at those 3, but if we're missing out on the love, compassion, erotics, if we're not talking about sex, sexuality, sexual health, we're missing out on holistic care there. Okay, so a really good opportunity there. Now, this one, this is a poster I often show my students. I got it off the internet, and it just shows some of the great benefits of having sex. Okay, just look at those for a moment. Now, imagine downstairs in the entrance hall, people are coming in here. Imagine if you had a lovely big poster up like this, but if you all constructed it by asking your clients, so what does sex mean to you, and how does sex seem to make you healthy? Imagine if you did a big poster like this for your clients, right? And just see what it means to them. Now, at this point, I just want to show you these 3 letters here. It comes from a book called Teaching Backwards by Griffiths and Burns, and what they refer to is KWL. What knowledge have you got? What more do you want? And then finally, as a review at the end, and what did you learn? So let me ask you just to talk to each other for a couple of minutes. What knowledge have you already got about taboos in relation to God, sex, death and dying? Okay. So what knowledge have you already got? But then, what more do you want? So from a session like this, or from further education, what more do you want? Okay, and then we'll finish off with the L later on. Okay, so just talk for a couple of minutes, please. So what do you know already about taboos in relation to God, sex, death and dying? Alright, so what taboos in relation to God, sex, death and dying? What taboos do you already know about, and what more do you want to learn?
Child abuse.
Okay. So you know about that?
Well,
yeah?
but I'm saying that I know. Well, we hear a lot more, don't we, in the media?
Yes.
But the sort of perhaps religious orders that were involved with child abuse, and understanding why people didn't say anything.
Yeah.
Was it fear? Was it, what were the reasons that everybody knew? I mean, but it was a taboo, no one spoke about it, and yet people knew what was happening.
Yeah. And especially now is that there is more media awareness that lots of people in the past may have just, that's what happens, that's how people thought of it in the past, and now there are different ways of thinking about it. Yeah. In fact, one of my students once said to me, we were actually talking about this when the Jimmy Savile stuff first hit the media. One of the courses I run is called Contemporary Issues in Sexual Health. So that was the contemporary issue, that's what we were talking about. And she said she went home and told her mother what we were talking about. And her mother said that she'd been a secretary in a big, huge open plan office back in the 1960s. And she said there was only one man there. There was, all of us girls were just one man. And say his name was Fred. Okay? And she said we all used to call him Randy Fred, because when any of us girls went up to the photocopy machine, Randy Fred would rub himself up against us, and we'd all laugh over coffee. Look what Randy Fred's been doing again. Now that's the way they dealt with in the 1960s, but now with today's look back, very, very different. But not only the abuse when you think of sexual abuse, it could be other types of abuse as well. Yeah. Okay, yeah, lovely, thank you. Thanks. Anything else?
Sex and sin.
Yeah. And what does Foucault say on that? Right, okay. Sex and sin, yeah. And that taps immediately into things like guilt. So if people have done things in the past, and especially look at the way this morning when we're talking about bargaining. Someone will, I promise I'll be a good person from now on. I promise I'll go to a place of worship every week. There's a bargaining, saying, well, if I change my life around. Now, when we were also talking this morning about how far can we go in talking to clients about religion. Suppose a client says to you, what do you believe about God? How far do you go in discussing that? When I worked on that HIV ward, because I'd only just left the priesthood, I didn't really want people to know I'd been a priest. So I'd been out of nursing for 10 years, so they put me on a D grade. Remember those old things? Yeah. So they put me on a D grade, saying, right, he's been out for 10 years, he's here. But the ward, it was all the nurses there, was really, really significant. About 50% of them were lapsed Irish Catholics. And the other 50% were more sort of evangelical Christians. So we used to nickname the two groups, the lapsed and the Christians. And when they all found out I'd been a priest, the lapsed was, oh, he's one of us because he's lapsed. And the Christians were saying, no, he's one of us because he's a priest. So there were these two different groups, but one of the nurses in particular, she had to be disciplined in the end because it was found out that she was going around to the patients, most of whom were gay, and dying with an AIDS-defining illness, and she would say, what you've done in life is wrong, you need to repent of it. So there was that type of stuff. So that's abuse. That's professional abuse. So yeah, especially this stuff about sex, and because sex is a sin, even when you think of some of the words we use, like if somebody says, oh, I was really promiscuous in my life, personally I would say that the word promiscuity, it's not a sexual word, it's a moral word. And it's going to mean different things to every single one of us in this room. Yeah? Or if you say, oh, that person was unfaithful. The couple might have had a relationship, but they say, well, look, we can be completely open. You know, see whoever you want to, as long as you don't bring anything nasty back home, you know. So in that case, what does infidelity mean in that relationship? So we have to be careful about using not just the sinning words, but any moral or moralistic words. Yeah? Because look how there's a difference. If it's a man that's had loads of sexual partners throughout life, people, you know, Jack the Lad, that one is. But if it's a woman that's had the same number of sexual partners, bit of a slap at that one. Yeah, straight away you can hear the words in society, the way they deal with people because of genders, quite differently. Yeah, so gender's going to be really important. Ooh. Okay, yeah. Thanks. Yeah, so that sin one really is important there. Okay, lovely. Anything else? That's a really good idea.
You wouldn't actually have, you know, that isn't necessarily just available. Yeah. And also when it comes to caring for someone who has built out, you know, you mentioned like knocking on the door and they don't answer, then you automatically think that they need help, and you might walk in on something. And it's like understanding the health and
really, fantastic. Yeah. Well, that's just not it's not just privacy, but that's respect. That's respect for people as well, isn't it? Now, look how that can tap into a whole load of other things. And in fact, there's a really good a free document. If you sign on to the Royal College of Nursing's website and just search for sexuality issues in old people's homes. I think that was the name of the document. This is free to download. And it's a really positive document on how to deal with issues exactly like this. Because say, for example, if the client that you're caring for, supposing now they've got some sort of cognitive impairment, maybe dementing, and the partner comes into you and says, oh, look, the thing I really miss is, you know, my wife and I used to lie on the bed together every afternoon and just cuddle. And then we turn around and say, well, okay, put a sign on the door, you know, please do not disturb. But all of a sudden, somebody goes in one day and finds that they're getting a bit more than just cuddling together. But how do you know the person who's now got some cognitive impairment has got the mental capacity to consent? So there's all those issues as well, about consent, you know. But that shouldn't stop. Yeah, right, so that shouldn't stop you doing all of this. So please have a look at that RCN document, because it's very, very empowering. Okay, what were you going to say?
Well, it's not that one patient may be vulnerable physically, one patient may have dementia. Yeah. And it's about, you know, how do you look at the risks they pose to each other? One may pose more to the other. Yeah. And how it's an ethical decision. How do you know, who decides? You know, how does that happen? Yeah. What comes first? I'm not in the science work, I don't know.
Yeah, that really is important then. Yeah. Have a look at that RCN document, because it really does deal with issues like this. And at the back of the document, there's all the legal stuff that you need to know as well. Yeah, lovely. Anybody else?
We had an interesting experience. Jim, we all remember this a couple of years ago in the unit of a rather young guy, probably very early 20s, who was dying. And he wanted nothing more than prior to him dying to experience sex and have sex. And we really struggled with how we could make this dignified, private, all that stuff, absolutely recognising this was a real desire of his. But that he didn't have a girlfriend. So this was around, therefore, where does the hospice sit with employing prostitutes? And also then, where would we find a prostitute who would be able to perform some kind of dignified act for somebody who was physically very weak, wasn't he, Jim? But Douglas House in in Oxford, which was the adolescent hospice unit, they actually had a really useful document, and we did get as far as pursuing, and his mum was involved in so this was not kind of stuff. We did get involved with this not charity, but company that provides prostitutes or sex workers for people with disabilities. But unfortunately, what happened is we did look at the profiles of these women were probably all in their 50s. He was a guy in his very early 20s, which in itself was a bit grotesque for him. Anyway, that's the story. But it was a really
excellent
big one for us as a hospice. You know, golly, we're actually talking about some serious stuff here. And there were some people who were absolutely rich. This is a hospice, you know, and got very into the fact that this was an immoral thing we were doing.
See, those words, immoral.
Absolutely, it fed into lots of people's real
taboos.
Sadly, he died, but he died knowing that we were looking into this. And we kept it very much in the loop, didn't we, Jenny, when we were going through, you know, I mean, literally of photographs of, I mean, some of these women did not look, not quite what we thought would be other than some kind of grotesque experience.
See, now, so that RCM document, especially in the final bit of it, talks about those dilemmas. Because say, for example, if somebody's in a care home and they say, well, look, I've got the money, so I want a commercial sex worker. I want someone to come into me. So all the stuff about privacy is their money. It's their right. But then, what about if it's on somebody else's premises? That's the one thing. And the other thing then, if you make that phone call, that's against the law. That's procurement. Okay? If they can make the phone call, that's entirely up to them. But if a third party does it, so have a look at that RCN document, and what you need to do then is see how it would apply to your own settings. And if you're advanced in talking about this now, then whenever that situation happens again, you're ready for it. Yeah, lovely. All right. Listen, do you mind if we stop this bit here? Because I can see the time's going on. We're never going to finish. Is that okay? We could have had a whole day, really. Right, these are some of the outcomes. So certainly that we'll discuss, and we have started discussing them. Even the language. See, you know when I said that P word, promiscuity, it's a moral word, not a sexual word. Even like prostitute, when you think of the stigma that's loaded with that, so the preferred term now would be commercial sex worker. So what's the abbreviation? Certified social worker. So they don't like that. Okay, right. This is what we need. So talk about this, but also it's from the point of view of if a person's got a sexual partner, intimate partner, whatever the term is you want to use, if they've got a partner, they've got losses as well. It could be them saying, well, look, my partner and I used to have sex regularly. I used to fancy my partner. Now I don't. So there's losses for the intimate partner as well. And they need to be listened to. Because if everyone thinks, oh no, we're caring for the patient, all our effort must go to the patient, and not for the carer, who's there for that carer? Or what happens if that carer then says, well actually, I've got sexual needs as well, and what I've been doing is, when Marie Curie nurses come in and stay all night with my wife, I'm popping out and having sex with somebody else. Now, think of the guilt, the angst that they may go through, because they may think, I've been unfaithful. All the moral terms we're looking at, they may think, I've not done right by my partner. So all of those things, so somebody needs to listen to them as well. Okay? Also, we need to explore the opportunities, and that's what we're doing there, exploring the opportunities for talking about this. And I'd say, if it was on that form, whatever you thought, I forgot the name of it again. If it was on there, something about sexuality or sexual health, even if you said to your clients, look, it says on here, sexuality. Is there anything about your sexuality or sexual health that we can help you with? Even if you just say like that, you've opened that to them. And they can say, well, thank you, no, not at the minute, but at least they know you've asked them. Okay, so that's going to be really, really important there. And what I want to end up doing is to show you a really good model that you can actually use to do this sort of stuff. Is that okay? Yeah, great. Okay. So very quickly, you just call out then, what are the opportunities you've got for discussing any of this with your clients? So it's not on that form, so you haven't got that opportunity, but what opportunities would you have then?
That's supposed to be a fact, isn't it?
No, it's meant to be a microphone. Microphone for you all to call out. So what are the opportunities? So when you meet clients, maybe for the first time, or you've been visiting them for a while, what opportunities have you got to discuss any of these issues?
When you're talking about their daily life, or if you're in the room and they're watching television or reading a book, or you notice the type of the book or anything like that.
Lovely. So using triggers to talk about it. Yeah, brilliant, okay. Yeah.
I notice people talk more outdoors when they're walking.
Oh, yeah. Yeah.
Because it takes away the focus from the subject.
Yeah. Yeah, so finding sort of recreational time to be with people, not just the therapeutic time, if you've got a bit of extra time to be with them, or be with them in different ways.
It's really nice.
Yeah, because some people may be a bit too nervous to stare you in the face as they're talking about these things. Yeah.
The effects of treatment.
Yeah. And when would you tell them about the effects of treatment?
Perhaps when if they're booked to go and have treatment, discuss it with you, go through the whole thing.
Yeah, definitely, without a doubt. Yeah, so any of that. So think back to that holistic model, and even if you're looking at it from a physical point of view, is a person going to be more breathless? Are they going to be in more pain? Are they going to have parts of their body which atrophy and just look totally different to how they used to? Okay, so all of those things will be worth talking about, especially proactively. Because supposing a person says, well, since I've been diagnosed with this, the thing I'm really struggling most with is this awful, awful depression. So straight away a prescriber thinks, oh, let's give some antidepressants then. And maybe the side effect of the antidepressants is to cut down on their libido. And they may say to you, look, I know that my illness isn't going to get any better, but the only thing that's keeping me perky at the minute is the fact that I can still have sex. If you take that away as well, that's going to impact on their depression. So it shows how that holistic model is integrated there. Yeah? Any others?
Gender, maybe they'll open up to like a female to a female, or a male to a male.
Yeah. It could be that, and especially when you look at the gender difference in the room now today, then how many men that you care for example, have got the opportunity for a male? You know? And yet, sometimes it may work the exact opposite way around. If it's a man, especially if his sexual performance is no longer what it should be, he might think, well, I'm not really much of a man now. So to admit that to another man may be harder than... So it depends on the individual. Yeah? And another issue that a few of us were talking about over lunch is with some transgender people now, especially if they're getting dementia, and maybe they can't remember that they've transitioned. And you know, they look down below and they're different to what they were expecting. Or they're wondering why you're calling them by a name they don't recognise anymore. Now that's going to be something, especially for dementia care services, that really needs to be thought about. How do you deal with that? Because if you're dealing with a person with dementia and they're telling you really wacko things, do you collude with them or do you challenge them? So if they're now telling you that their genitals are missing or they've grown something that wasn't there when they were born, how do you deal with that? So again, having the forethought to think about it. Yeah. Okay, I still think your best opportunity is if you all nag that company to put that on the form. Yeah? If that's on the form, because then you can blame it on the form. You know, look, the form says, you know, if your form says spirituality, then that's a delicate thing to talk about. If it says that, why can't you talk about sexuality? Okay? So because the form says sexuality, so is there anything you want to discuss with us? And even if you don't want to today, know that you're more than welcome to at any point. You've opened the door to them. Okay? You've given them the opportunity. This is when I was going to tell you some of the stories. The one story I was going to tell you, I really can't now, because I know it always triggers tears. And it's going to be a bit difficult. But the story, like that woman of 80, it was a story similar to that one, but look how that taps back to all of this stuff then. So no matter what age of person you're caring for, what experiences they've had in life, it could be that they're looking back over those experiences. And all the stuff about anger, regret, bitterness, missed opportunities, all of those things could be different. Okay, and then William Shakespeare. Right, he came out with this thing, I guess loads of you have seen this one before. Give sorrow words. The grief that does not speak knits up the o'erwrought heart and bids it break. Now, I was going to ask you to do some group work at the moment, but we just haven't got the time for that. But what I was going to ask you to do was to split into different groups. So one group to think of older people, one to think of younger, someone for female, male, lesbian, gay, bisexual and transgender, and then the intimate partner. So if you'd all split into these different groups, what I was going to ask you about is, what losses do these people experience throughout the whole time that you're with them? So what sort of losses? So just shout out something now, to be able to time doing the group work. What losses related to the illnesses of the people you care for?
Perceived physical beauty.
Yeah.
Closeness.
Say again?
Closeness.
Energy.
Yeah, energy. Physical ability.
Independence.
Right.
Autonomy.
Yeah.
Hearing, seeing, smelling.
Yeah. All of those things, yeah.
Family.
What's that? Family? Yeah, it could be somebody that wanted a family. So it's a younger person that thought, oh, the way life is going to pan out, I'm going to meet somebody, get married, have babies, whatever, and now that's all changed. So it could be that, yeah. And somebody else says,
Anger.
anger at.
Well, angry at the situation, angry that if the sexuality has changed between them and the partner, that it's been taken away,
Yeah.
how to deal with it.
So there's another loss
Yeah.
taken away.
Yeah.
Yeah, it could be that, say, for example, if a couple have been used to having sex and now it's not, and maybe it's because the partner's thinking, oh, I can't have sex with you because I'm sure it's going to hurt. But maybe it doesn't hurt, but because that conversation has never happened, assumptions are being made. So the partner's thinking, well, I can't have sex with you because that will hurt you, and the other person's thinking, you don't want sex with me because you think I've gone ugly now. They're assumptions, but nobody's talking about them. Okay? Yeah, fab. So that's what I was going to ask you to do, but so maybe you will, when you see the video, think about these things from the different groups, because it could be, say with a younger person, it could be about family, but with an older person, it could be family as well. Look how many older people might have had an abortion before 1967, with backstreet abortions, and if they had some form of sepsis, never able to conceive after that, they may now be thinking, I wanted children. And because I had an abortion when I was young, it stopped me ever having children. So anger. But what happens if a person's really angry, if they turn it out towards others, what does it seem like? Yeah, all those things. It's aggression towards others. So how many times have you gone to a client and thought, oh God, that person is just so angry all the time. You know, they're not a nice person to be around. But that anger has come from somewhere. Something has caused it, and if it's not being dealt with therapeutically, then that's bugging the person. But what happens if they turn it in on themselves? Quite often that can lead to depression, low self-esteem, even just a death wish. You know, for some people it might be suicidal ideation. For others it might be, what's the point in the treatment? I'm going to die anyway. Might as well just get it over and done with. So a sort of a death wish, a passive death wish, because they're turning anger in on themselves. Do you feel comfortable saying to clients, is that anger I'm experiencing from you now? Will you be honest with that? If you felt a client was being angry, would you name it? Yeah? Yeah, lovely, great, okay, brilliant, thanks. Yeah, so that's what I was going to ask you to do, to go into those groups and to think about those things. Now, one of the groups we haven't mentioned much, lesbian, gay, bisexual and transgender people. Look how, say for example, in this part of the world, so here in Hertfordshire, how many LGBT people have you ever had in this hospice? How many LGBT people out there have need of a hospice but think, well, maybe they won't be nice to us, maybe they won't know what to do. So there's wrong assumptions again. So maybe a chance for you to advertise your services to local LGBT people's organisations. Let them know you're here. But also be proactive in dealing with difficulties. So supposing a person comes in and says, well look, my partner and I, we've been together for the last 30 years, we've never done the paperwork, so we're not civil partners, or we haven't got married or something, and then the one person dies. So who's the one to plan the funeral? Is it the partner of 30 years? Or supposing it's their estranged family that now comes back and says, look partner, we hate you, we don't want you around, this is our son, it's our body to look after. How do you deal with that? So these are the types of losses and experiences that the more proactive you are in thinking about them, the better you'll be in able to deal with these. Yes, okay? Yeah. Sorry we haven't got more time for this. But that's what I was going to ask you to do there. Also, when we talk about sexualities, and I'll send you some materials to read if you want to. This was something I published last year. And looking at sexualities, don't think you just have to put people into little pigeonholes. Because when I was asking you about that pigeonhole on the nursing documentation, and people say, wears makeup, lives at home with husband and 3 kids, over 40, somebody else might write that homosexual, lesbian. It can be so labelling. And supposing that person isn't out to other people, then straight away, so it can be so labelled, because what we need to realise is that for each and every one of us, we do have our own sexual orientations, but sometimes the label that we use for them doesn't match. So supposing you're caring for a man, especially from some cultures, a man from some cultures where he's expected to get married and have children, but maybe he really fancies the bloke next door. So he has babies with his wife because that's what his culture expects of him, but he's having the mad rumpy-pumpy stuff with the bloke next door. Yeah? So in that case, the identity doesn't necessarily match up with the orientation. Or it could be that their attractions are different. So you're caring for a husband and wife, and one of them says their wife, you're caring for her, and she says, look, my husband's always been good to me, but I've been good to him as well. I've given him all the children he wanted, but he's never had my heart. I'm in love with the woman across the road. So the attractions may be different to the label that's being used. And also then the behaviours. Now think of the guilt. If someone says, well, I know I should be home caring for my partner, but actually I'm sneaking out and having sex with somebody else. Now there's the capacity for guilt. And please don't be shocked that people have multiple partners. My poor old mother, as I say, she's been dead a while now, but she used to say, you youngsters, that's all you ever talk about is sex. It was never like that in my day. And it always tickles me with people when they say, well, my day. So wait, if you're living today, today is your day. Yeah, so when do you mean my day? Well, just after the war. I said, look, in Britain, for every man who fought abroad, 1 in 7 came back with a sexual infection. 1 in 7. And if he then had sex with his wife or his girlfriend or his boyfriend, and in the 1950s with all this stuff about chlamydia and infertility, nobody knew about it. Okay? So it's always, there's nothing new under the sun. It's always happened. But maybe we're just talking about it more now. Okay? And certainly when you're talking about sex and sexual health, realise, don't just put people into little pigeonholes. Even if you write on somebody's phone, you're married, that doesn't preclude wandering eyes, anything else. Yeah? So try not to pigeonhole people. Yeah, that's just, that used to be in my garden. Just to show that we're all different. Every single person's unique, every single person is different, and we need to consider that when we are working and dealing with people. Especially from the point of view of LGBT, it could be that somebody, especially a transgender person, it could be they say, well look, actually I'm a man and I was married to a woman for 30 years, and only after 30 years, after bringing up our children, did I then decide to transition. But I only want to go as far as dressing in the clothing of the opposite gender. I don't want the hormones, or I don't want the operation. So it's, where is a person in relation to that? Now, I've noticed all your toilets here, you've got male and female signs on them. That's fantastic. But look how many organisations, especially big hospitals, may say, oh no, if it's a transgender person, well, let's put them in the side room. And what happens if somebody's pushed in the side room? Nobody goes in and talks to them. There's isolation, stigma, taboo. You're not talking about them. Okay? A filing cabinet, the bottom drawer stuff. A friend of mine did her PhD looking at the psychological impact of abortion on women. And when I read her thesis, the one little thing that stuck in my head about this is one woman referred to her abortion as her bottom drawer stuff. Now in the UK, by the time a woman reaches the age of 40, 1 in 3 will have had at least one abortion. So that's a lot of people, and yet how many feel comfortable talking about it? And what this one woman said, it was her bottom drawer stuff. She said the top drawer, that's what you show to the whole world. That's what everyone sees about you. The middle drawer, that's a bit more private. That's just for your family and your loved ones. The bottom drawer, that's the stuff you never talk about with anyone. Now, does that mean they're going to take things to the grave with them? Or are there things they need to get off their chest? Okay? So, really important there to consider that, the bottom drawer stuff. And obviously, the more you talk about all of this, you're going to be giving them great hope. Because they may say, oh, you're the first person that's ever mentioned this to me. Or you're the only one I feel I can talk to about this. You're giving them hope where they might have thought things were going to be hopeless. Mind der Begegnung. There was this fantastic German Jewish philosopher called Martin Buber, and his mother gave him away when he was a little baby, and he didn't meet her until he was 38 years old. And when they met, he said their eyes met, but there was a mismeeting, a Begegnung. He made up that word. He said there was a mismeeting between them. So as two people, their eyes met, but they weren't really meeting as people. Okay? And especially with sexualities and sexual health, lots of people feel it's out there, it's outside of me, because we're not seeing it as an integral part of the individual. The more we address it, the more we're letting them feel, you said, whole beings. The more we address it, the more we let them be whole beings. And this is the final model I wanted to finish on now. We've just got a few minutes left. Have you heard of the Plissit model? No? Nobody? Okay. Plissit. P-L-I-S-S-I-T. Okay, so I'll send you articles on this. Okay? Plissit was first designed by a sexologist in the 1970s. And what he thought of was give people permission to talk about it. So look, on our forms, it says sexuality. Is there anything you want to talk about in relation to sexual health? And that's a closed question. Is there anything you want to talk about? No, thank you. It's personal. You've closed them down immediately. So with permission giving, look at ways of being open with them. Okay? The LI stands for limit. Don't worry, I'll send you articles on this. The LI is limited information. So they might say, well look, actually, the medication I'm on is causing me to have really dry vagina. And intercourse is difficult now, so I've sort of given up on sex. Does that mean I can never have sex again? So you might say, well, look, I don't know exactly what creams you can use in relation to your medication, but I know exactly where to get a form for you, a leaflet. I know where to get information for you. Okay, so limited information. The SS stands for specific suggestions. You might say, well, no, and I'm not a prescriber, so I can't prescribe the creams for you, but in fact, one of our other nurse practitioners is the one that deals with all of this. Would you like me to refer you to that person? So you're making specific suggestions. And the IT stands for intensive therapy, and that just means referring someone on when you've got to the edge of your competence. So if they start asking you stuff now that you really don't know, rather than close your body language and close up, look, I don't know about that, we better not talk about it. Rather than that, you could say, well, no, I don't know too much about transgender people's issues, but I know our hospice is dealing with the local LGBT organisation. I can certainly get you an appointment there. Right, you've referred them on. Now that was implicit, and like with Elizabeth Kubler-Ross, the way people thought, oh, you've got those 5 stages, you've got to work through them, from anger through to acceptance. The bloke that designed this, J.A. Anon, he never intended it for it to be implicit in a long line. So these people, Taylor and Davis, have put it into this big circle. And what they've done is to say, that's the bit that's focused on the client. So you're working with the client, this is what you need to do. But the outside bit is focused on you. And we all talk about reflective practitioners, so this is the bit for us. So how self-aware are we? Supposing a person starts talking to you about sex, say for example what you said about that young man, suppose, oh that's disgusting, straight away, your body language. Or if you suck a bit of lemon, you're showing by your facial expression that this is not appropriate. Or if someone, well, for goodness sake, you've got cancer, surely there are other things you ought to think about. You shut them down. So you need to be self-aware. Okay? The next bit of it is to reflect. So reflect on practice as it's happening. Reflect on the practice, in practice and on it as well. So, say for example, when I'm teaching, standing up in front of a group like yourselves now, if I could see you're all looking bored and you're looking at your watches, I need to reflect on that. And then maybe I'm going on too long, maybe I need to shut up, okay? So reflect, and all of us are called to be reflective practitioners. Also review it. It may be that you think, I'm sure I said the wrong thing to that person, but at least you're going to learn from it. You'll never do that again. Say for example you're working with an LGBT a transgender person, and you say, is that the same as a drag queen? You've said the real wrong thing there, yeah. But I said the wrong thing. I need to understand things better, and that's where you can tap into your knowledge. If you realise there's stuff you do not know, find out how you can know about it. Okay? It's no good saying, oh, well, I dealt with that badly, I'll never have to deal with that again, because you might have to deal with it again. So, knowledge. And also the final one then, challenging assumptions. And that could be in yourself or them. So you might say to them, look, our form says, would you like to talk about sexuality issues? And they may say, well, no, that's not appropriate to talk about that with you. So you might need to challenge their assumptions as well as your own. Okay? And if you do that, you're meeting this first section of the code of, from the Nursing and Midwifery Council. You're putting the interests of people using or needing services first. Everything it says there, you are doing if you address people holistically. Okay? And I think that's the last one now. Yeah, and that's what I was going to come back to. So, what did you know, what did you want to know, and what have you learned now in this hour or so? We've shot over time, so let me finish it there. And that's it.
Thank you.
Okay, sorry for the mad rush.
Thank you so much. I could tell everybody was held. Nobody was rustling their papers. Thank you so much for, again, lots of food for thought. I think that implicit
model is wonderful for everything we've talked about, isn't it? It's about permission giving, that we just need to open up, that people can talk about these taboos. We might have some information that we might need to pass on
I'll
to
send
other
you all
people.
the stuff.
So in some ways that was a beautiful summary as well of everything that we've discussed. So thank you for getting us thinking. I think we'll have to invite you back for a whole day on sex and sexuality. So more time.
Thank you.
So thank you so
Lovely,
much.
and thank you all for letting me be here for the day.